The following program is in no way intended to replace your doctor's advice or treatment program, nor should it be used as a tool for the purpose of self-diagnosis.
Good evening and welcome to another edition of Your Health, Your Choice. It's Wednesday, the 10th of April, 2019. I want to wish a belated birthday greeting to Travis. And this evening we have with us, as usual, I'm Linda Banks-Khan, and we have with us this evening, as usual, Dr. Claude Khan, community diabetologist, medical practitioner award winner 2013, and also pastor of the Anaposis Chapel.
Good to be here.
So this evening we're going to be looking at chronic kidney disease, but I know you want to share something quickly on immunization and...
Yeah. Well, I wanted us to be topical, and in fact, chronic kidney disease, the reason we decided to do that tonight is that we recently heard that Trinidad, one of the leading kidney specialists in this country, was saying that kidney disease, we are leading per capita population for chronic kidney disease worldwide, and that was quite an astounding statement. But I wanted to make just a short discussion on immunizations, first of all, because there's what we're calling an anti-vaccination movement in Trinidad right now, Linda, where there are lots of people, some fitness or health coaches, they're called, or people from alternative branches of medicine that are actually encouraging people not to take vaccinations. Now, there's a wide range of vaccinations. Of course, there's a flu vaccination, the influenza vaccination, or the H1N1, that was the Minister of Health was encouraging people to take. And, you know, I found after December, there was a rush for people wanting it. And then suddenly in January, February, many patients were coming in very skeptical about it. So it seems that people were successful in encouraging those high-risk groups. And so I want to emphasize that. I don't think everyone needed the influenza vaccination, but high-risk groups, diabetics, asthmatics, hypertensives, etc., and young kids certainly needed it. Yeah. The other thing I want to mention is that you may have seen on the news yesterday that New York has just established a new precedent where they are trying to threaten parents to prosecute them if their children are not immunized against measles. And just before I came here, I looked on Facebook, and there was a discussion on Facebook whether this is right or not.
Infringing on the rights of parents.
On parents. But, you know, what people forget is that things like polio was eradicated because of immunizations. Smallpox, a scourge, killed millions of people, was eradicated because of immunizations. In the last 100 years of medicine, immunizations have been one of the most important discoveries. I graduated in 1989, and I've probably never seen measles. And yet we have now an outbreak of measles in the United States, in Africa, and children in Africa are dying because of measles.
So by not immunizing, you are actually putting other people's lives in danger.
Right, so you're putting your own kids at danger, and there's what is called herd immunity. So the less people are immunized, the greater the risk of the outbreak of these diseases.
Okay. And I think I read somewhere that this whole anti-immunization campaign started with one article written in 2012 and was taken up by the Russians very vigorously and spread, you know, through social media, based on one article written in The Lancet, I think it was.
Right. And that is probably one of the things that we heard. And then earlier on, the whole, I think it started with the MMR, where there was some articles written about a link between MMR and autism. And I want to say very, very strongly that has never been proved to be so. And I want to again state to all those who are not trained in this field, please be careful how you encourage people not to take vaccinations. And the idea that vaccinations are somehow suppressing your immune system, the whole idea of taking a vaccination, yes, it's sometimes a small dose of the actual virus, but it's meant to activate your immune system. So if you are infected by the real virus, you are able, your immune system is primed and able to fight it off.
Okay. So is that what you want?
Well,
we're going to talk about a little bit about obesity as well.
Right. So a few weeks ago, we know that there was the whole thing, our former Minister of Health talking about obesity, and a lot of people took exception to it. In fact, you pointed out in one of the newspapers that Dr. Khan shamed people, and he said you hope that...
Fat shaming really isn't on.
Right. But you said you hope that people didn't mistake the two Dr. Khans. Well, I'm sure they didn't, because he's much more famous than I am. But we have an obesity problem in this country. In fact, we have an obesity problem worldwide. And we need to talk about people who are overweight. We need to talk about preventing our children from putting on weight. We know that obesity can predate diabetes, hypertension, cancers, you name it, lots of illnesses. So we are not...
Statistics actually show that students have doubled in the number of obese students has doubled in schools recently.
Yes. And so obesity is beginning from young kids. But the point is, fat shaming does not help.
No.
Linda, I have a lot of patients who come in and are desperately trying to lose weight. They're exercising, they're trying to eat healthily, and they're just not able to shift the weight. Obesity is now considered a chronic illness. So I want to emphasize this to the viewing audience. Obesity is considered a chronic illness. So it's not just people choosing to be overweight. So genetics are important. If you have family members, your parents were overweight, you're much more likely to be overweight. Your metabolism, it could be an endocrine problem. We know that there's a brain dysfunction. The hippocampal area of the brain is often changed in people who are obese, and the appetite-seeking behavior changes. And the point I'm making is that, just telling someone to lose weight and you're bad, and your
negative reinforcement doesn't work.
It does not help.
Yeah.
So I want to encourage those who are trying to lose weight. You need to, go to your healthcare professionals. There are various interventions that can be offered, and sometimes you need psychological input, etc. There are weight loss clinics in this country. Some good, some not so good. What I'm saying is that this is a problem. It's a medical problem. It's not just a lifestyle problem.
So it's about modification of behavior, but it's also about therapy, maybe dietary therapy.
Dietary therapy, exercise. And of course, there are now some drug therapy that is available. There's also surgical interventions for those who are extremely overweight. Expensive surgery, not available on the government service, gastric bypass surgery. But the point we're making here is that we are sympathetic as healthcare professionals to those who are battling with their weight, and we are here to help you.
Who are battling against any disease.
Any disease, yes. We want to discuss the factors for chronic kidney disease. We want to discuss the progression of chronic kidney disease. We want to discuss this whole concept of testing for microalbuminuria. So that's a term that we will discuss. And by the way, I'm not a kidney specialist, so I'm a community diabetologist, and we probably will have a kidney specialist on, a nephrologist, maybe in the weeks ahead. But what we wanted to do is just paint a broad picture today. Yeah,
but there is a connection between diabetes and chronic kidney disease.
Right. So let me just say at the very outset, diabetes is one of the major causes of chronic kidney disease, but there are other causes that we will come to. So I think this...
Is he ready with the slide?
Not the slide, the little clip. If we are ready with the clip, we can play that at this stage.
Okay, so that was quite a good comprehensive analysis of chronic kidney
Yes.
disease. And I guess we learned it was quite fast-paced, so we're going to slow it down a bit and break it up into defining perhaps what is chronic kidney disease.
Right. So slide 3, we have a kind of definition of what chronic kidney disease is.
3.
Okay, slide 3. Right, there it is. Sorry for the slight glitches, it's our fault. So classified as chronic kidney disease is classified as you can either have classical diabetic nephropathy, which is just one of the causes of chronic kidney disease, where you have this concept of persistent albuminuria, which is protein in the urine, or you can have significantly reduced kidney function, and that's where we talk about this term GFR, glomerular filtration rate. So we can just come off that slide.
So basically the kidneys are filtering fluids and balancing fluids in our bodies.
Right, so it's responsible for the electrolyte balance, sodium, potassium, etc., and acid-base balance in the body. And basically, yes, the kidney is a filtering organ. So the blood is coming through the arteries that lead into the kidneys, and then the basic unit of the kidney is what is called a glomerulus. And that's where the filtering mechanism.
So we have slide 3, I think, which talks about the glomerulus.
Slide 4.
4, yeah, the GFR.
Right. So slide 4. So when we talk about the glomerular filtration rate, we're talking about grades 1 to 5. Grade 5 was stage 5 of chronic kidney disease, is where it's quite advanced. The patient may need dialysis. The glomeruli are filtering at less than 15 mils per minute. And then you have stage 1, 2, 3. At stage 3, you can talk about stage 3A and stage 3B, and then stage 4, and then stage 5. Now, So I just want to come off that slide for a minute, because there's often a little bit of confusion when patients see this staging. Because previously, up to about 2 years ago, what we would get on our lab reports was the serum creatinine, and the doctor would then have to calculate. There are two or three equations we can use. One called the Cockcroft-Gault equation, where we put in the patient's creatinine, so the serum creatinine is the basic waste product that is measured, and if that is retained, the kidney is not filtering properly, the creatinine is retained in the body and it goes up, and then that can be plugged into an equation. Now, what is happening is the labs are actually calculating it for us, and that's what's called the estimated GFR. The problem is that patients look at their reports now. I have quite a few patients who analyze their reports before they come in.
That's all right. I would do the same.
Absolutely. No, I agree. It is the patient's right to do that. But they see a GFR of 70, which is grade 2, and they get worried because the report is saying this is grade 2 chronic kidney disease.
Okay.
When in fact, we would say that anything above 60 to 65 is considered normal renal function. Now, there are some conditions that you can have a GFR of 90 and you may have initial damage to the kidney. But what I would tell patients overall, now not all labs do the estimated GFR, but few of the larger labs are doing the GFR for us so that we don't have to calculate it. But so the way we really define chronic kidney disease is on the basis of either having persistent protein in the urine or the GFR. Looking at the GFR.
So the glomerulus is part of the kidney that does the filtering.
That does the filtering, yes.
So if that is damaged, then you get protein in your urine.
Right. So what happens over a long period of time is that, and the little clip, I always forget that word, clip that we showed that there is, because of high blood sugars, and we're going to look at some of the risk factors again, but you have scarring of the kidneys, and as a result of that, the filter, the little pores in the glomeruli are enlarged, and you have, as the blood comes in, you have protein leaking into the urine. Normally, you should not have protein in the urine at all.
Right. So we're heading to our first break.
Already?
Yeah, it seems as though this has gone really quickly. When we come back, we're going to be looking a little more at risk factors, the prevalence of type 1 diabetes and how it connects with chronic kidney disease, the natural history of it, and then some assessments and how we actually treat with hypertension and diabetes, because they're all connected with this CKD.
Yes.
So don't go away. We'll be right back with some more on CKD and your health, your choice.
In this time of challenges our nation is facing, an intervention from God is what we need. Do you need a breakthrough in your life, family, and business? Life Vision Ministry and the Trinidad and Tobago Christian Churches present a National Healing Crusade 2019 with returning evangelist P.S. Rambabu from India.
When you go through Moses, you go to God. When you go through Jesus, you meet the Father.
Join us on Thursday, the 11th of April to Saturday, 13th of April 2019 at North, Central, and South Trinidad.
Enough you worshipped Him as God. It's time you know Him as your Father.
Come experience the power of God as we impact our nation to reach its destiny through the miraculous power of Jesus Christ.
I believe you're my healer. I believe you are.
Welcome to the Chronic Kidney Disease Program at University of California, San Diego. My name is Danuta Trzebińska and I'm a nephrologist in our clinic. In this module, we'll talk about symptoms of chronic kidney disease, or CKD. The symptoms associated with chronic kidney disease worsen as you progress from the least severe stage, stage 1, to most severe stage, stage 5. Patients who have chronic kidney disease stage 1 usually have no symptoms. The only exception is patients who are spilling a massive amount of protein in the urine because they can subsequently develop swelling in the legs or other parts of the body. Now, chronic kidney disease stage 2 is usually associated with no symptoms either, just like stage 1, you don't know. The vast majority of patients with CKD stage 1 and 2 are not aware of having kidney disease unless they undergo specific blood and urine testing. So most of the time it's incidental finding. You are not even looking for it. Now, chronic kidney disease stage 3. This is the most common stage of kidney disease. This is middle road. Your GFR is between 30 and 59. Since this stage is associated with moderate reduction in level of kidney function, a proportion of patients might develop some symptoms. And what kind of symptoms? Some of those symptoms, like fatigue or more frequent urination at night, are non-specific and overlooked by patients or attributed to some other things going on in their lives. Think about this. There's a very long list of causes for fatigue, and kidney disease is certainly not number one. Some patients who are in chronic kidney disease stage 3 can experience swelling in the legs. Now we're moving on to stage 4. Stage 4 is associated with further reduction in the level of kidney function. It's considered severe. GFR is between 15 and 29. Thus, as you can expect, there will be more patients having symptoms in this stage. Symptoms can be similar to those with stage 3, but they're just more obvious. There might be some additional symptoms like decrease in appetite, or some patients will experience shortness of breath. Now we are moving to stage 5 chronic kidney disease, and this is the most severe stage. If you recall, in stage 5, GFR is less than 15. As with other stages, various patients will experience different amounts of symptoms. There are certainly many people in this stage who continue to work full-time and live a pretty much normal life. You look at them and you would never guess that they have chronic kidney disease stage 5. They ask me, "Doc, are you sure?" I feel just fine. I cannot tell. In general, however, in this stage, there are more symptoms than in any other previous stages. On top of previously mentioned symptoms like fatigue, swelling in the legs, patients might suffer from some other symptoms like skin itching, metallic or bitter taste in their mouth. Sometimes I ask patients, do you feel like you swallowed a coin? Not that I know what it tastes like, but it's just that your taste is off. Sometimes patients experience nausea or even vomiting, and this nausea and the vomiting might be more pronounced in the morning. When you're in stage 5, you can expect further worsening in energy level and some sleep disturbances. Some patients will require more sleep at night. For example, instead of your previous 6-7 hours, which was enough to feel refreshed, now you will need 9 hours to feel rested or semi-rested. Or maybe you're going to have a reverse sleeping pattern. That means that you will stay up at night, you're just not sleepy, you cannot sleep, and then you will want to sleep all day long. Or some patients, they sleep at night just fine, but they also require a nap during the day. They will tell me, Doc, I go to work, I can get through work, but then when I come home, I really need this nap, and they didn't need it a year ago. Many patients, when they are in stage 5 chronic kidney disease, they are in denial. All those changes are very slow. It's not like one day you have 100% of kidney function and the next day you wake up and your level of kidney function is down to 10%. So you really have to pay attention to your body, how you feel. We tend to adapt. If I have less energy, all right, I'm not going to run, I'm going to do less. I might sleep more. Oh, I don't have an appetite, so I will eat less. But sometimes people don't notice. So when you come to see us in clinic, especially when you're in chronic kidney disease stage 5, we'll ask you very pointed questions. How much do you sleep? How many hours? Well, how many hours did you sleep a year ago? How much do you eat? Well, is it up or is it down? All those questions are helpful. Some patients in chronic kidney disease stage 5 suffer from muscle cramps, even when measured electrolytes in the blood are normal. Sodium is normal, potassium, magnesium, so please do not self-medicate yourself. Don't just start taking magnesium supplements when you get cramps, because you might overdo it. You might notice worse concentration, or actually you might not notice, but somebody else around you will notice that you are not as sharp as you used to be. Some patients might feel more cold than usual than previously. Your urine volume might drop, you'll be peeing less than you did previously, and maybe swelling in your legs will get worse. Sometimes when you are in stage 5 chronic kidney disease, blood pressure control becomes more difficult. We have to add another agent and blood pressure keeps creeping up. Patients who have diabetes might have more episodes with low instead of high sugar. That's one of the findings of advanced kidney disease. To summarize, please remember that chronic kidney disease is a silent disease, and some patients will have just non-specific symptoms only, which are often ignored or overlooked till kidney disease is quite advanced. Let us go through a couple of questions to check your understanding of this module. Question number 1. Which stage of chronic kidney disease is associated with most symptoms? The correct answer is chronic kidney disease stage 5 is associated with most symptoms. This is the most advanced stage of kidney disease. If symptoms are severe enough and or some of your labs are dangerously abnormal, you might need to start either dialysis or undergo kidney transplantation in stage 5. Let's do one more question. Which symptom would you not expect to occur in chronic kidney disease? Is it A, fatigue, or B, leg swelling, or C, increase in appetite, or D, muscle cramps? Let's think about this, and which symptoms would you not? It's a tricky question. And the correct answer is C, increase in appetite. If anything, there is decrease in appetite in advanced kidney disease. Some people lose weight. All other symptoms often occur in patients with chronic kidney disease. So you will experience fatigue, leg swelling, and muscle cramps. All right, congratulations to you guys. You have completed the module on symptoms of kidney disease. Please check our website for additional educational modules on kidney health. Thank you.
Welcome back to Your Health, Your Choice, and I hope you got that question right. So another surprising fact that we learned about the kidneys, and I'll ask Josh if he can just bring up the slide showing us the actual where the kidneys are located in the body. Did you know that the kidneys were once thought to be where our conscience was, feelings of right or wrong? Also, that I've forgotten. Yeah, the body's blood flows through the kidneys every 10 minutes. So blood is filtered 150 times a day in that system.
So as you look at that diagram, you can see the kidneys are on the flanks, on the right and left side, and out of the kidneys, well, you can see the arteries bringing blood to the kidneys, which is the red,
one, yeah.
and then the blue is the artery, the renal veins taking the blood out. But when you slice the kidney, you begin to see the inside of the kidney, which is the glomeruli, etc. And then you have what is called the ureter. The ureter leads from the kidney down to the bladder. So the organ at the very bottom there is the bladder. So we can just come off that slide, and I just wanted to emphasize that a lot of patients come in with back pain, and the first thing they think, oh, it's my kidney. Most back pain is not due to your kidney. It's muscular or it's musculoskeletal. So the kidney is basically on the flank area right here. And the way when we examine, we do something called palpation, where we put the two hands on the tummy and we try to see if we could feel if the kidney is tender, enlarged. If you have a kidney infection, for example, you might be very tender in the flank area. And of course, the other common problem with kidneys is kidney stones. Now, one of the things I want to differentiate is the difference between a nephrologist and a urologist.
Okay.
Because I think people get a little bit confused by that. The urologists, they deal with the mechanics of the kidney and the bladder and the prostate, whereas the nephrologist is dealing with the actual functioning of the filtering through the kidneys, and they're dealing with chronic kidney disease. So a lot of people end up going to the urologist when their creatinine starts going up, when they should be going to a nephrologist. So a nephrologist is not a surgeon. The urologists deal with if there's a kidney stone obstructing flow of urine from the kidney. They deal with bladder problems. They deal with the prostate, etc.
So the urologist is a surgeon, and the nephrologist
is a physician.
Is a physician.
And the physicians are the ones, the nephrologists, and of course family doctors and diabetic doctors like myself, we deal with the earlier stages of chronic kidney disease. And then the general indications are when the GFR falls below 30, 30.
Define GFR again.
So GFR is a glomerular filtration rate. That's when the patient should be seeing a kidney specialist.
Okay. So let's look at some of the risk factors for CKD then. So
we can bring up slide 5. And on slide 5, we have some of the risk factors. So for chronic kidney disease, poor glycemic control, so diabetes, hypertension, very, very important.
So that means that blood glucose and blood pressure are
extremely important. Now, there's a bit of a genetic predisposition. If there's a family history of kidney disease, there's something called polycystic kidneys, etc. That can be a predisposing factor. Hyperlipidemia, now that's high cholesterol. A lot of people don't realize that high cholesterol can lead to chronic kidney disease. Ethnicity, there's a little bit of debate about that, whether the Afro-Caribbean population is more at risk than the Indo-Caribbean population. And of course, long disease duration. The longer you have diabetes, hypertension, high cholesterol, the greater the risk. And of course, what a lot of people don't realize, smoking. That's very important. Now, so that is where, you know, when you see a patient, we have kind of now calling our center the Diabetes Wellness Center. And by the way, we our main center is doing a little bit of advertising in Vistabella, but we are now in the Penal area. And people who are interested in finding out about that, it's at Dr. Biku's office at 1190 SS Erin Road, 324-0720. I'm just mentioning that because people often ask me, and of course, we are not the only people dealing with diabetes wellness. There are lots of other centers, but we do have a center in Penal, one in Shogunus, and one in Vistabella. The reason I'm saying that is when you see a patient in the early stages, what we are trying to do is prevent chronic kidney disease.
Yeah. So the next slide, I think, slide 6, shows us the prevalence of CKD in type 1 diabetes.
Right. So, there's been, in fact, a decreasing incidence over the past 35 years because we are getting better at treating type 1 diabetes. The overall incidence is about 2.2%, after 20 years of type 1 diabetes. And after 30 years, about 8% of the type 1 diabetics will have a degree of chronic kidney disease. There was a major trial done which reported an incidence of 9% after 30 years, even in those who were intensively controlled. So we could just come off that slide. And so that's a little bit concerning that even in type 1 diabetics, now remember, very often type 1 diabetes will present in the early years, teenagers or even babies, and by the time they get to the 30s and 40s, they've already had diabetes for 30, 40 years. Now,
so a lot of the organs would have been affected.
Right. Now, you know, the sad thing about, the good thing about diabetes is if you work at your diabetes and hypertension and cholesterol,
That's through dietary,
etc.
behavioral modifications.
And medication.
And medication.
Because remember, if you're type 1, you need insulin.
Yeah, you need the insulin.
Right? I mean, I have patients very often coming in and who are type 1s and saying, can I come off insulin? But that's a misunderstanding. They can't. But if you are well controlled, you can prevent a lot of the problems. But remember, your body has a metabolic memory. So unfortunately, very often in the adolescent years, people are not well controlled. It's a well-defined phenomena. And then as they get maybe to their late teens, 20s, people begin to look after themselves. But they've already had 5 or 10 years of poor control. And that's already
damaging.
Yeah.
I was looking at some of the statistics again, that diabetes is actually linked to 4 million deaths annually, and it's not just from diabetes, it's the other organs that have been affected.
Well, and I don't want to just concentrate on the diabetes tonight, because hypertension, I just wanted to talk a little bit about hypertension, because in some ways, hypertension when people have sustained injury to the kidneys, hypertension becomes even more important than the diabetes. But the problem with diabetes, people don't die of diabetes, people die of the complications of diabetes.
So that's where the 4 million a year.
Yes, absolutely.
Okay. We want to look at the natural history of the disease, CKD. So that's slide 7.
Right. So we can bring up slide 7, the natural history of chronic kidney disease. So what is this albuminuria? So let me just re-emphasize that albuminuria is protein in the urine. And many times, in a lot of patients, the urine is not being tested for what we call microalbuminuria. So if you look at the left-hand side of the slide, 10 to 15 years before you get into chronic renal failure, you are spilling small amounts of protein in the urine, and that is called microalbuminuria. So you start with normal, no albumin in the urine, then you have microalbuminuria, which is called incipient diabetic nephropathy, and then you go on to proteinuria, which is overt diabetic nephropathy, and then you get to chronic renal failure. I don't want to get into the actual amounts of urine. The point I want to make here, though, is often patients ask me, do I want to test their urine? And I say, well, no, I don't really want to test your urine in the office. I want to send your urine to the lab to test not for sugar, but to test for protein.
Right. Because as we were saying, if the filtration system in your kidney it's damaged, then you start leaking protein into your urine.
Right. And that starts with small amounts of protein that cannot be detected on a normal dipstick. So if you're just testing a patient's urine with a normal dipstick in the office, you will miss early microalbuminuria. And I know I have a slide talking about why that is important. We know that it predates chronic kidney disease, but what we want to do is pick up people with between 30 milligrams to 300 milligrams of protein over 24 hours in their urine. That's microalbuminuria. And then we don't want to wait until it's above 300 milligrams. By the time you get to that stage, you're picking it up on a normal urine dipstick, and that then is you're already getting into maybe stage 3 chronic kidney disease.
CKD.
Yes.
And do you want to look at some of the factors that affect albumin secretion?
Right. So we said what are the risk factors for chronic kidney disease. We're going to come back to controlling diabetes, controlling hypertension, etc. But there are some reasons for protein in the urine that is not really indicating chronic kidney disease. So this is just a little bit of a side note that not everyone with protein in the urine will have chronic kidney disease. So slide 9.
Yeah.
Slide 9 talks about, so exercise. If you exercise vigorously,
you're excreting water.
You're breaking down muscle. During the menstrual cycle, you have protein in the urine. Pregnancy, you have also excessive protein. Poor glycemic control can have transient protein, and then that can be recovered, and then urinary tract to vaginal infections can lead to that.
Okay, so those are the things that affect albumin secretion.
Yes.
All right. What about the diabetic renal assessment?
Right. So diabetic renal assessment, the patient comes in, of course, and I know time has gone very quickly tonight because we have
10 more minutes. So
we have a shorter program. So you want to take a careful history from that patient. If the patient is having swelling of the ankles, and let me just say very quickly, the majority of patients with swelling of the ankles have no kidney disease. It's very often venous insufficiency. And I know patients are worried
about fluid retention.
And certain times of the month, females tend to retain more fluid than others. So let me just say that very quickly. But you want to take a careful history. Is the patient short of breath? Is the patient having swelling of the ankles or the legs, etc.? But the basic investigation is sending the urine off to the lab, testing for micro. So every diabetic patient should have at least once a year their urine sent to the lab to test for microalbuminuria. Now, and we're probably not going to have time to show this slide. Why is that important? In type 1 diabetics, it is indicating incipient diabetic nephropathy. But in type 2 diabetics, microalbuminuria is a marker for vascular disease. What do I mean by that? Yes? This.
Keep going.
This is a key thing to understand. If a type 2 diabetic has microalbuminuria, you want to protect them against heart attacks, strokes, and peripheral vascular disease, disease to the legs. Because what it's indicating is that the arteries are becoming almost inflamed, and that patient is at risk not just of kidney failure, but now you are much more likely to want to put that patient on aspirin, put that patient on a cholesterol tablet, and be very aggressive in treating the blood pressure. Okay. And of course, you must send the blood for testing for creatinine, electrolytes, etc. And if the GFR is less than 60 every 3 to 6 months, you should be repeating these tests.
So where do you want to go next? Because we have to look at hypertension, we have to look at medication. Do you want to look at medication? Because you've spoken about hypertension.
Right. So the interesting thing about this is that the evidence we have, let's just talk about type 2 diabetes, that if you don't have chronic kidney disease, tight blood pressure control and blood sugar control is very important, and cholesterol, to prevent the onset of chronic kidney disease. So I want to be very careful how I state this. So if you don't have chronic kidney disease, good blood pressure control, good blood sugar control, very, very important, and cholesterol. If you have established chronic kidney disease, the evidence for tight blood sugar control is less than the evidence for good blood pressure control.
So you can have your sweets, but you need to control your potassium? And sodium?
Right. Potassium. Well, you're making an important point there, Linda. The potassium and sodium is they're very important. But what we notice in people who have chronic kidney disease, the blood pressure becomes increasingly difficult to control because the kidney actually is very central in controlling blood pressure. It releases something called angiotensin, and that in the whole, and you can have something called renal artery stenosis, which is narrowing of the arteries to the kidneys, and the blood pressure becomes very difficult to control. And the higher the blood pressure, the greater the scarring. So in established kidney disease, you want to make sure that the blood pressure is around 130/80, 120/80.
That's interesting, because I always just assumed that the kidneys had to do with fluids in the body, but and maintaining that balance. But I learned today that they also produce a hormone
Hormones.
that keeps blood pressure normal.
Normal. Absolutely. And so when the kidneys are damaged, what you have is that whole renin-angiotensin system, which is called, and now, so we have classes of drugs. I know time is going very quickly tonight. We have classes of drugs that are now aimed at controlling that renin-angiotensin system. So we have something called ACE inhibitors, as one of my colleagues calls them, the PRILs, enalapril, lisinopril, Covasil, and then you have the ARBs, the angiotensin receptor blockers, things like irbesartan and candesartan, a whole group of tablets, that valsartan, and there are various trade names. So what we often, now you can't combine those two groups of tablets, but very often what we find with hypertension and diabetes in chronic kidney disease, you have to use 2, 3, 4 different drugs to control the blood pressure.
Right. Okay. Okay, so do you want to look at some of the nutritional needs, or do you want to just go straight to the summary slide? Because we have 4 minutes left.
Right, the summary slide was slide...
29.
Slide 29, okay.
Josh?
Are we going to bring up slide 29? Okay. So
the summary slide, yeah.
So we know that diabetes is a common cause of chronic kidney disease, but we know that blood pressure and blood cholesterol are also common causes. There are various grades of nephropathy, and when we talk about the stages of chronic kidney disease, we talk about stages 1 to 5. The higher the A1C, the higher the risk. Blood glucose control matters, but blood pressure control is essential. So I just want to come off that slide, and before we end, just say, we've talked about high blood pressure, we have talked about the blood glucose, and we've talked cholesterol, but there are other causes of chronic kidney disease, autoimmune diseases, things like systemic lupus, and there are other causes of autoimmune diseases that can also lead to chronic kidney disease. So I don't want people going away thinking it's just blood sugar and high blood pressure. I have focused on that, on those, because those are the most common causes. And also, there are some drugs, the non-steroidal anti-inflammatory drugs. I have had quite a few patients who have ended up with chronic renal failure because they have abused painkillers, things like cataflam, Olfen, etc. If you're young, Olfen, cataflam might be okay occasionally, but if you are above 50 to 60, I am now, especially if you're diabetic, I am not wanting to give my patients those particular tablets.
I know that that's a big concern too, that we are so intent on not wanting our children to experience pain that we put them on painkillers at a very young age.
Yes.
And so they don't know what a pain threshold is, really.
Right.
It becomes more difficult later on.
And of course, in chronic kidney disease, let me just say there's some medication that we have to take patients off. We didn't have time to talk about that, but we have to take patients off metformin. Sometimes if they're on sulfonylureas, we sometimes have to decrease. And interestingly, people with end-stage renal failure, their insulin requirements decrease because the body is not clearing the insulin. So very often we find that we can almost take patients off insulin when they end up. No, I'm not even talked about dialysis.
Yeah.
So maybe another, when we get a nephrologist on, we can talk about dialysis.
Yeah,
But insulin requirements and requirements for blood sugar control actually decrease when you get to chronic kidney disease.
Okay, so I think we've come almost to the end of the program. That was pretty quick this evening.
Yes.
So we've been looking at chronic kidney disease, but I know that you normally put your pastor's cap on at this point.
Well, this program is going to be played tonight. It's been played tonight, and we want to apologize again for
late
delay and for not being able to call in. But you can ring in your questions on 482-4269 during the day, or you can WhatsApp your questions on that number. So let me call that number again.
It's on the screen.
It's on the screen. Thank you. 482-4269. So by next time, we'll be going back to the live questions. And let me just, before I put on, because this is going to be playing over Easter, this particular program, remind you that our diabetes wellness centers, we are based in Vistabella. On that number, we are now based in Penal, 1 day a week on 324-0720, 324-0720, and we're also based in Shogunas and Caroni Savannah Road. I think we have
1 minute
one
left.
minute. So I want to encourage you as we come up to Easter. Easter is the pinnacle of the Christian calendar. We start with Palm Sunday at our church at number 12 Johnson Street in Koki, 9 a.m. And then we have a Holy Thursday service, and then we have Resurrection Sunday. And really, the crucifixion and the resurrection of our Lord Jesus Christ is central to the gospel that we preach of Christianity. And it's good news. It's good news that in the midst of the darkness of this world, God sent his son Jesus to die for the sins of the world. For God so loved the world that he gave his only begotten son. Why not celebrate Easter with us?
Okay. Thank you again. And as we wrap up Your Health, Your Choice, I wish you over the Easter celebrations and resurrection, your physical revitalization, emotional upliftment, relational connections, and spiritual strength. Your Health, Your Choice will return in a fortnight's time with another program, but you can see a repeat of this one tomorrow and on Sunday.
At 6:30.
6:30 on Sunday. So good evening, and thank you for joining us.